Welcome back to this new episode of Pediatric Talks with Dr. Kazmi. Today we are going to talk about prolonged undifferentiated febrile illness in children. We will be basically taking a diagnostic and management approach to this problem. So without further ado, let's dive and get started. Now, prolonged febrile illness is any illness in which there is fever for more than 14 days. So fever for more than 14 days is known as prolonged fever. And undifferentiated means that even within these 14 days, there is no possible sort of a clue to the underlying reasons for this fever. In other words, this might be a fever without localizing signs persisting for more than 14 days. Now, this might be presenting as daily mild fever or daily spiking fever. It might be associated with some generalized non-specific signs, like the parents might complain that the child has got reduced appetite, he's lethargic, he's not playing, he's sleeping most of the times. But when you do the physical examination, by and large, most of the time the physical examination would be normal, except even if there are a few signs, there might be non-specific generalized signs, but by and large most of the physical examination is normal. Now, the clinical relevance of this presentation is that it usually presents as a diagnostic dilemma in pediatrics, because obviously the signs are very non-specific or non-existing. It's very difficult to pinpoint as to what is the underlying cause that might be causing the fever. And the other thing is that because the fever has been a prolonged now instance, in this particular case for more than 14 days, the parents are also worried, and you may be thinking that is there any serious cause for this prolonged fever. So it's very important, and it also becomes a challenge at the same time to differentiate between the benign and serious causes of this prolonged fever. So the key learning objectives of this particular lecture is that number one, we understand the proper differential diagnosis for prolonged fever for more than 14 days. We identify that what are the appropriate investigations to carry out in such cases, and what will be the best evidence-based management strategy for these type of children who have got prolonged fever. Now, before we start, it's very important that whosoever presents with an undifferentiated fever for more than 14 days, it's very important, first of all, to ascertain whether this is one instance of a prolonged fever or whether this prolonged fever is basically various chunks of recurrent episodes of febrile illnesses. What I mean is that, like, let's say a child comes with this complaint of more than 14 days of fever. Now, one possibility is that there is some single cause for this prolonged fever, right, which started and is causing this prolonged fever. Or the other possibility would be that this child has got multiple instances of back-to-back infections or something which are causing discrete episodes of fever with some respite in between, but it looks like that this child has got a prolonged fever. Why? Because it has been happening over a prolonged period of time. So basically the child would fall either under one of these two categories, that it's a prolonged real undifferentiated fever, or it's a recurrent fever in which there are various episodes of fever, discrete episodes of fever, because being caused by different reasons. Now, let's say if the child has got this prolonged fever because of a single instance, like the fever has been continuing for without any respite, then it can be further caused by three different things. One is that what we call as a factitious fever. We also call it not fever of unknown origin. It simply means that parents think that the child is febrile, but in fact he's not febrile. They may say that the child has been feeling warm to touch, he's lethargic, he's not playing, but in fact he's not actually has got fever. So there will be two clues to that. Either there will be no history of a documented fever of more than 38 at any point of the day during these 14 days. They would say the child simply feels warm. They would even say now the child feels warm and he's probably hot to touch. But when you take the temperature, the child would be absolutely fine. The temperature would be absolutely fine. It would be within the normal limit. So that patient is not truly having fevers, and it's just because of various maybe hormonal changes or autonomic changes that the child feels hot to touch but is not having any fever. He might be having some other condition, but at least not a febrile illness. The other category is what we call as fever of not unknown origin. What does it mean? It means that apparently seems like this prolonged fever is fever of unknown origin, but it's not unknown origin. The origin is known. The diagnosis is readily available. Why? Because in most of the cases, this is usually an unusual presentation of a common thing. So The common things, the common illnesses that occurs in children. Now, for example, like lower respiratory tract infection, you all know it would present with fever, with cough, with difficulty in breathing, and maybe some focal signs like crackles on chest examination. But sometimes the same lower respiratory tract infection might present with prolonged fever. There is no cough, there is no difficulty in breathing, the saturations on room air would be absolutely fine. And even when you are examining the chest, you might not noticed any crepitations or focal signs. But if you do a chest X-ray, you will see that there is a big consolidation. So that is basically an unusual representation of a lower chest infection, which in fact is a common thing. So either you have got an uncommon presentation of a common thing, or the other possibility would be you are dealing with a rare thing. That is what we call as a common presentation of an unusual thing. For example, you might have come across Kawasaki disease or some other form of vasculitic disorder, which are rare things, but uh, that is the common way they present with prolonged fever. So either an uncommon presentation of a common thing or a common presentation of an uncommon thing. That's the best way to describe them. And the third is really fever of unknown origin, where there are daily fevers for more than 14 days, and they can have like various underlying causes. It might be caused by infectious etiology, various types of viral bacterial infections. It might have an inflammatory etiology, generalized inflammation in the blood vessels or in the body. It might have an underlying neoplastic reasons, certain form of occult cancers, or there might be miscellaneous reasons. There are certain reasons like, which are grouped into sort of a miscellaneous group, or sometimes despite all the investigations, even the second line investigations, you don't find any reason. We call it really febrile illness of unknown origin, that there's no diagnosis. So these are the three categories in those children who have got a single reason for fever going on for more than 14 days. And then in the second category is those kids who present with fever for more than 14 days, but basically these are discrete episodes of something happening at regular intervals. So it might be what we call as back-to-back viral infections. Kids less than 5 years of age, because of their immature immune system, they are exposed to different type of viruses, especially when they're going to the school or to the nursery. They get exposed to these viruses, they develop an illness, they get better. Within a couple of days, they may go back and they pick up another infection. And parents, they think that he's probably down with the same thing over a prolonged period of time. In fact, this is quite normal, and he's getting a sequential, like back-to-back self-limited illnesses. Or sometimes they might be having periodic illnesses. Like periodic illnesses, some kids have got cyclical neutropenias where they are like white blood cell count, especially the neutrophil, it drops at regular intervals, and during that time they can pick up an infection. Or it might occur in cases of certain disorders like periodic fever with aphthous stomatitis, pharyngitis, and aginitis. We call it PFAPA. Or it might be because of there are other types of cyclical disorder like familial Mediterranean fever and things like that, which can occur at regular intervals and can give a febrile illness. But these are basically discrete episodes which are occurring at a regular interval. So this is the framework of looking into the theoretical framework, the knowledge framework of looking into any child who is presenting with the prolonged fever of more than 14 days. So this is the thing that you should keep it in your mind. Now, let's talk about some of the causes of these prolonged fevers, whether they are prolonged fever or whether they're recurrent. Now, we talked about the unusual presentation of common things. So, various viral illnesses can cause back-to-back, infections, or sometimes the same common viral illnesses may present in a very unusual way. For example, a simple viral infection which can present with fever, with a runny nose and sore throat, might present with just simple fever, okay, prolonged fever, and this can happen in a few instances. Usually, the same viruses which would give you a very sort of a typical picture can sometimes present and give you a very unusual presentation. This can happen. I mean, it's quite common. So that can also happen. Sometimes, as I told you earlier, that kids who are going to nursery or school, they pick up back-to-back viral infections. So like one infection, they get better, pick up another infection, and then pick up another infection. And let's say within a month or 1.5 months, they might present with what looks like as a prolonged illness, in fact, which are that discrete episodes of back-to-back illnesses. Certain types of chronic bacterial and viral infections. Now, certain infections are really chronic. For example, certain viruses, Epstein-Barr virus infection, cytomegalovirus infection. Now, when a child gets infected by these things, these are chronic infections. Now, they would persist for more than weeks because these viruses are thriving in the body. They give you a low-grade infection. So obviously the symptomatology would be mild, the signs are not that much, but the infection is there. Certain types of bacterial infections like endocarditis, sinusitis, UTI, osteomyelitis. These are low-grade infections, and they might present just with fever of prolonged illnesses rather than, presenting with an acute fever with very overt signs. So sometimes these like can present with just fever of prolonged origin, and probably these signs are minimal. Certain types of inflammatory conditions which have got an autoimmune etiology as well, juvenile idiopathic arthritis, especially the systemic onset JVGIA. Before these kids, they develop specific signs of joint pains. They usually present with spiking and daily fevers for a considerable period of time, maybe on and off rashes. So that's quite characteristic of systemic onset JIA. Kawasaki disease presents with fever for more than 5 days. They might have rashes coming and going, though it's got a typical picture, but sometimes an incomplete Kawasaki can present a diagnostic challenge. Multi-system inflammatory disorders secondary to COVID. This has come up after COVID. These kids might have COVID in the past, like a couple of weeks or months ago, and then they usually present with inflammation of 2 or more systems. And that can present with fever of prolonged origin. Various vasculitic disorders, so vasculitis, small cell vasculitis, medium cell vasculitis, like vaginous granulomatosis, HSP. So they can present in a very unusual way, and they can present with prolonged fever of more than 14 days duration. So these are some of the common causes of prolonged fever. Then some of the uncommon and rare causes of the same fever prolonged origin, that could be malignancies, especially in kids, leukemias, lymphomas, or neuroblastomas, nephroblastomas. They can present that way. Periodic fevers, as I told you earlier, PFAPA or familial Mediterranean fever can present that way. Certain types of endocrinopathies, hyperthyroidism, or adrenal insufficiency can present with sometimes with a fever of prolonged origin. Some types of atypical infections, which are zoonotic in origin, like brucellosis, caused by consuming raw milk, or cat's catch disease caused by, Bartonella hansi, or tuberculosis in high risk groups, especially immigrants, opportunistic infection in those who are immunocompromised because either they are taking some form of anti-cancerous medication or on steroid therapy. So they can have, like, for example, histoplasmosis can cause prolonged fever of unknown origin. Certain drugs themselves can cause fever if taken over a prolonged period of time. Certain antibiotics being taken, presumably for viral infections, if they've been taken for a prolonged period of time, themselves can cause fever. Certain types of anticonvulsants like phenytoin, carbamazepine itself can cause fever. And then there are certain miscellaneous conditions like dysautonomia, diabetes insipidus, ectodermal dysplasia, and deep-seated big hematoma. I mean, as the hematoma gets broken down, it can produce pyrogens, and that can cause fever for prolonged origin. So these are some of the uncommon and rare causes of fever, which sometimes can present for more than 14 days duration. Now, it's very important, that those kids who are presenting with fever of more than 14 days duration, and there's, let's say, no clear-cut like signs, and the child is well, it's important that for a few days the fever pattern is monitored. Or in case, let's say, if the parents are quite clever and they have monitored the fever or documented the fever, to look at those charts of fever. For example, in a true fever of unknown origin, you might see that there is fever on and off, sometimes spikes, sometimes not spikes, and it goes over a prolonged period of time. In autoinflammatory conditions, you might see that there is a pattern of spiking fevers, then low-grade fever, then spiking fever, and they are occurring at regular or irregular intervals. While in cyclical fevers, you would see that the fever spikes at regular intervals. So just looking at the charts or looking at the timing of the fever can give you a rough idea. It doesn't mean that, they are pathognomonic or diagnostic of the underlying condition, but they can just give you a clue, so at least you can narrow down your differential diagnosis. Then coming down to the million-dollar question, how do we work up these kids? Now, every child requires some basic workup who presents with fever for more than 14 days duration, especially if the fever is a real fever, it's a documented fever. So basic workup requires looking at the white blood cell count and in the inflammatory markers. So this is very, very important. You need to see what is the white blood cell count, especially with the subtypes of neutrophils and lymphocytes. You also need to look at the inflammatory marker. It's very important that while you are requesting for the full blood count, you also request for a blood film, that is the special smear to look at the morphology of the blood cells. Sometimes it gives very valuable information as to what is going on, especially if the child is suffering from vasculitis. So not only the inflammatory markers will be raised, but you might see some form of RBC morphology or RBC damage like schistocytes, things like that in the peripheral smear. You also need to do the basic metabolic profile, doing the liver and the renal function test, which will look at your liver enzymes and at your urea, creatinine and electrolytes. You have to take blood cultures. It's important to take 2 or 3 bottles for blood cultures. One bottle is not enough. It is important to take at least 3 samples for blood culture. It's also important to do urine analysis and taking a sample for urine culture and a chest x-ray, even if there are no respiratory symptoms, because earlier we were talking about that sometimes it might be an unusual presentation of a common thing. So you might think that, okay, well, fine, this child has got fever and there is no need of chest x-ray because there is nothing on the chest and the child is not coughing, but he might be hiding an underlying lobar pneumonia. So it's important that you do this investigation, especially if you are dealing with a child who's got prolonged febrile, undifferentiated febrile illness for more than 14 days. So always do a chest x-ray even if there is no chest symptom. Important, chest x-ray even if no chest symptoms or no chest signs. Also, you can consider certain types of specific studies like stool studies. You can send stool for fecal calprotectin. Some cases of inflammatory bowel disease would show you like your increased fecal calprotectin. And abdominal ultrasound to look for a deep-seated abscess is also important. Sometimes that can also present with fever of prolonged origin. And in certain cases where you might think that the child is immigrant or has got a background where he might have been exposed to tuberculosis, you can do the tuberculin sensitivity test, the interferon gamma release assays, and the chest x-ray as a part of the TB workup. Then some kids might need advanced investigations that includes the viral serology. These are quite expensive tests. So like, if you think like there is some underlying, sort of a viral phenomena, chronic viral phenomena, so then you can consider for doing PCRs for or serology for Epstein-Barr virus or cytomegalovirus or certain types of bacteria like Bartonella hensai, cat's eye disease, dengue, and brucella. But again, that would depend on the condition and the circumstantial evidence. We might think of the advanced tuberculosis testing, like taking sort of samples or bronchoalveolar lavage for TB testing, things like that. Or maybe if there's a lymph node enlarged, might take a lymph node biopsy as well. In certain cases, you might have to consider rheumatological workup like anti-nuclear antibodies, rheumatoid factor, HLA-B27 to sort of diagnose if there's an underlying element of juvenile idiopathic arthritis or underlying lupus or vasculitic disorders. And in malignancy, if you are considering malignancy with your full blood count, it's important that you order a smear, you order LDH and uric acid, because that will be usually raised in leukemias and lymphoma. And sometimes you don't see anything in that and you're still suspecting because things might not be present in the peripheral blood, but they might be present in the bone marrow. So bone marrow aspiration might be considered where indicated. So the $1 million question is, if all these investigations are normal, what should you do? Now, it's very important that in most of these cases, there is something which we might have missed in the history and examination. So there might be a missed clue. So it's very, 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 very important to revisit everything. So reassess. So if you think everything is fine, start back from the very beginning. Reassess history. Take another history. Go through each and every fine detail. Examine each and every system. Normally, we as a doctors, what we do is we are used to focused examination. Somebody comes like with a cough and difficulty in breathing, we would focus on the chest and probably we won't pay any attention to the musculoskeletal system examination or maybe the abdominal exam. But in this particular case, you have to examine each and every system: musculoskeletal, neurological, cardiac, respiratory, genitourinary, everything. Everything has to be examined in detail. Then important thing is that those kids who are well, they can go home, but you have to tell the parents that they keep a chart, daily chart of, mm, sort of, marking the fever, and consider the repeating the investigation after 1 to 2 weeks. So if the investigation at this point in time are normal, you send them back, they keep a chart, and they come back after, let's say, 2 weeks, and you repeat the test, you repeat the history, you repeat the test, because sometimes the signs may develop late. Sometimes the blood test, initial blood test might be fine, but maybe after a week or two, you will see that certain things have gone deranged. So it's important that in all these cases, the diagnostic workup is, if the child is well, I mean, if he can go home. But obviously, if he seems very unwell, you will admit them. But if he's well, they go back, they keep a chart of fever. Number two, they come back in a 2 weeks time for repeating the investigation. If the second is also fine, again they go back, do the same thing, and in the third visit, which will be 2 weeks after the second one, the same tests are repeat. So it's important to repeat the investigations after a 2 weeks interval till you get something. If they are going home, again, there are two schools of thought. Either you can tell the parents just to wait, okay, and you can give some like sort of medication, paracetamol, or you might start, empirical antibiotics or empirical anti-inflammatory therapy. Again, there are two schools of thoughts. It depends which school of thought you belong to. There are quite a lot of arguments on both sides. So I'm not going to delve into that. It depends. It's on the pediatrician discretion. But some of the red flags which would require admission and further immediate investigations are if the child has got documented persistent weight loss, he's complaining of night sweat, he's got unexplained generalized lymphadenopathy, or you find he's got organomegaly in the form of hepatosplenomegaly, things like that, or the symptoms are worsening despite getting supportive care, which is like, giving paracetamol for fever, good nutrition and hydration. So in a nutshell, the management approach is that they should be well hydrated. They should be, the focus should be on giving them good nutrition and symptom management. Empirical antibiotics might be considered, again, as I told you, if you depend, if you belong to that school of thought, if you think that there is might be a bacterial infection, the same goes for inflammatory conditions, and you might have to refer to specialists like the infectious disease specialists or rheumatologists or oncologists if you think there might be an underlying reasons for these prolonged fevers. So the take-home messages for this lecture is that prolonged fever always requires a structured approach, requiring a very, very thorough history and examination, and maybe history taking and re-examination. The investigations, they guide further management, and if the investigations are normal, they should be repeated. If there are red flags like weight loss, night sweat, that should prompt urgent referral. And sometimes a multidisciplinary approach like oncologist, rheumatologist, pediatrician might be required for a complex case. So my friends, this was all about prolonged fever in children, prolonged fever that is present for more than 14 days. I've tried to simplify it for you. So remember, these uh, illnesses might be because of unusual representation of common things, or it might be because of common presentation of uncommon things, or it might be because of back-to-back infection. So how do you know? Again, it's very important you take a thorough history, you do a thorough examination, you have to do some investigations, and if everything is normal, you might have to re-examine and redo the investigations every 2 weeks till you get an answer. If there are red flags, they need to be admitted, and appropriate management be done. I hope you have learned something. Have a very good day. Take care. Bye bye. I'm signing off.